Hi, and welcome to today's talk, The Link Between Dysphagia and Posture. I'm Julie Fietta. I'll be moderating today's session and will provide the CEU code at the end. I'll both verbalize that and drop it in the chat. Before we get started, please remember to mute yourself throughout this presentation. Questions can be asked using the chat feature. So with that, I'll go ahead and turn it over to our speakers, Filipe Correia and Bart van der Heyden.
Thank you.
Bart, can you, perfect.
Yeah. Here we go.
Hey guys, so first of all, it's a pleasure to be here at this first virtual ISS. It's a challenge for all of us, but it's quite exciting, this new age. So my name is Filipe Correia. I've been in the industry for the last, I would say, 24 years, working in the seating mobility market. I've been around for quite a while. I did a lot of work with clients throughout Europe. I'm from Portugal, throughout Europe and Latin America in particular. And I've been working as a consultant for many years now. So this is my a little bit about me. I'm gonna let Bart introduce himself. Bart.
Right, and I'm Bart. I'm from Belgium. Also famous for beer, chocolate, all the things that you like to swallow. So I'm a physical therapist. I have worked in the United States for a little bit, and now I have my own clinic back home called Private Practice the Kine, the physio. We have a small team, and I'm also running courses throughout the world under the name of Superseding. And yeah, very excited to have you here and looking forward to the discussion today.
Perfect. So these are goals for our session today. So we have our goal is to list at least 2 seating interventions benefiting the client with dysphagia. We're going to also be able to list at least 2 validated dysphagia assessment tools. And then the third one is going to be able to describe the physiology of the preoral anticipatory phase, the oral phase, pharyngeal phase, and the esophageal phase, and the variables impacted by seating. Okay, so these are going to be our session goals, and it's going to be an exciting session. It is for us, so I hope it is for you guys too. Oh, and Bart. So we're going to talk about dysphagia. Okay, but these are definitions that we have referenced out there. I'm just going to read the first one that says dysphagia or difficulty in swallowing is a serious, life-threatening medical condition that affects a substantial number of patients with neurological impairments or neurodegenerative diseases. Okay, but, and there are several, and I'm not going to read all of them, but dysphagia is a very large term. Okay, so we need to be more specific for each phase of the swallowing process we're looking for, or we're talking to, if we are connecting that with a particular seating intervention. So this is what we're going to do today. So we're going to have Bart talking about, all the muscles and all the phases of the dysphagia of the swallowing process, and then connect them with a specific seating intervention. So it's going to be a lot of information. We hope that we're going to answer all your questions, and we'll be free to answer questions in the end if you want, or if you need to. Okay, so and I just want to introduce you. This is Leslie. Okay, I don't know how much you guys have seen head support or head positioning trainings in the last few years. This is a video of Leslie. Leslie's a dystonic young lady, not so young right now. It's been a while, this video. It's an amazing video at feeding time for a dystonic client. And this is a challenge for both the client and the speech therapist, in this case, feeding her. And we're gonna use this video, snapshots of this video throughout the presentation as an example of things that we're trying to achieve. And my first question to all of you, and to start off the presentation before I hand it over to Bart, is what do you think is wrong with this picture? Okay, and this is just stay with this question in your mind, and then we'll come back to Leslie in the end of the presentation. Bart?
Right. So what we're going to do now is, if it's okay with you guys, well, we don't have a lot of choice here, but if we want to solve a difficult problem, what do we need to know? So we have a client with dysphagia. So the first thing we need to know is what is our knowledge about dysphagia? We're going to discuss all the different phases, but also the specific seating interventions that you can expect to go along with all the problems in different phases. And then, of course, you need to assess with your client to find out exactly what phase is disturbed. The assessment scales will help you for this. And then the next step is to set your seating goals, because we have specific seating interventions for every specific problem. And then we're going to define and execute a seating strategy, and then you measure outcomes. So that's how you can use this information. And we're going to start off. And the first thing you want to do when you want to eat something is to have a look at it. You have to know that there is food. So I don't know what time it is right now where you are, but we have just about dinner time. I see a juicy burger. We are hungry. So the first thing we need to do is we need to see the food. And in order to see the food, it's not so easy, because normally when the food is on your plate, it is at the front of the client. And on the plate, if you're looking at your line of sight, the horizontal line of sight is basically where you see all the data and where you can actually process what kind of food it is, what the structure of the food is, what it is exactly. And the food here is placed on the plate, and it's on 70 degrees, so it's right outside of the line of sight. And if you're looking at the blue line of sight, that's only when you see, that's actually only where you can detect movements. You don't really see what it is. You see something moving. So if somebody's taking the burger and he's taking the shortest route from the plate down to the mouth of the client, it's almost borderline visual field. The client is perhaps seeing a movement, but doesn't really know if it's food or not that's being put in his mouth. So even though it's tempting to take the shortest route from your plate to the mouth, it's not really good. It doesn't help the client with the anticipatory or the pre-oral phase. And during that phase, it's really important to see what's going on. Why? Because you need to open your mouth in order to receive the food. But the second thing is, and during the pre-oral phase, you will anticipate food by visual, smell, and being hungry, and that's producing saliva. And salivation process will be very important to create a mass that can digest and swallow the food, which we call the bolus. So it's better to place the food, even if you're feeding the client, you bring it to the horizontal line of sight slowly, and then bring it from the horizontal line of sight slowly towards the client and then towards his mouth. And that is the best preparation for the pre-oral phase. So with this client, we see that there's a couple of things wrong, and perhaps you notice them as well. Imagine perhaps you can do this yourself. If you turn your head towards the left or towards the right, and now you introduce food to the corner of the opposite side. So I'm actually turning to the left here, and my finger would be the spoon, right? I'm introducing the food here, and it's in the corner of my eye, but I see something, but I can't really see what it is. So if people have an asymmetric head position, the visual field is probably not detecting the food. I can barely notice there's a movement with my finger, but I can definitely not tell if there would be food or not. So horizontal line of sight, slowly towards the mouth, and then the client has the best possible pre-oral phase preparation. So that's definitely a problem. So after the pre-oral phase, we can definitely influence this with seating interventions. Filipe will discuss them. But afterwards, we have the oral phase. And during the oral phase, we're going to masticate the food into small particles. So mastication will be important. And by masticating the food into small particles, we create a bigger surface area for the saliva to adhere onto the food. That starts a chemical digestion. It lubricates the food, so it's easier to swallow from the oral phase to the pharyngeal phase. It also prevents abrasion because it will be a smoother transition, and the gastrointestinal lining will not be compromised. So that's the whole idea. So we're going to make the food into bolus, into a small bowl. And the oral phase runs from the oral vestibule. So this is a kind of a crazy image, but we remove the teeth on this display. And you see on the left a pink representation of the oral phase, the front. Actually, it's a space behind your lips, between the lips and the front of your teeth. That's what we call the oral vestibule. That's from the front and down to the back. And on the picture in the middle, you see the pharyngeal arch. And when the bolus touches the pharyngeal arch, we're going to go for the pharyngeal phase. But in the oral phase, it's basically that pink area from the oral vestibule to the palatoglossal arch. And now it's very logical. You see food, you wanna start probably starting to enter in the oral phase. But the problem now is that you have to open your mouth. And in order to open your mouth, what you need to do is you have to depress your mandibular region. And there are a couple of muscles responsible for this. You see the lateral pterygoid, and that's on the left, and it's hidden a little bit behind the masseter muscle. So it's this small muscle. I don't know if you can see my mouse. Filipe, can you see my mouse here?
Yeah, we can. Yeah. Mm-hmm.
Okay, that's fantastic. So it's this small muscle here. It's a fan-shaped muscle located at the intertemporal fossa, this area here. And what it does, it's helping to depress the mandibular, but it's also retracting the mandibula. So, but more important are the suprahyoid muscles. And the suprahyoid muscles, digastric, mylohyoid, and the geniohyoid, these are very important muscles for several reasons. They stabilize the hyoid bone, and the hyoid bone is very important to also have tongue action, especially during the oral phase when you're moving the food backwards to the pharyngeal region. Then you need to have the ability to move with your tongue, to move the bolus with your tongue backwards. So we have a couple of, so they stabilize the hyoid bone, which is a key stabilizer for the tongue and the actions of the tongue. They also elevate the hyoid bone. We will discuss this, don't worry, it's difficult, but I think we will manage. And they also widen the oesophagus. Oesophagus is important if it's widening because it can then receive the food, receive the bolus, and it's helping you with pharyngeal phase. We're going to go into details on a couple of the suprahyoid muscles. On the left, you see the digastric muscle, and this is the anterior belly, and this is here in front, so it's on the inferior part of the mandibula. And then you see that there is a tendon, and the tendon is connecting the anterior belly of the digastric with the posterior belly of the digastric, and that's extending all the way to the mastoid process. So you see this here. So it's this kind of muscle here, and then the tendon is connected with a loop to the hyoid bone, and that's the link on how that stabilizes the hyoid bone. The mylohyoid on the picture, the third picture from the left here, is basically this transparent layer of muscle. The mylohyoids are flat muscles, and they form a sling for the inferior part of the tongue. So it's this kind of muscle here, and it's supporting the floor of the mouth. So that's also important. And then you have on the right here, you see the geniohyoids, and they also depress the mandibula. You can see them. They are closer towards the medium part, internal part of the mandibula. And what they're doing is they are short, narrow muscles. They pull the hyoid bone forwards and superior. So they lift they move forwards and superior. So that's going to be a very important muscle for tongue movements. And it also shortens the floor of the mouth, and it widens the pharynx. So it's also helping to receive food after it has left the oral phase. So these muscles we have to keep a close eye on. So on to the next slide here. I think that's it. Here we go. Right. So what we're going to do is we're going to look at the suprahyoids. So again, they are also primary. One of the primary functions is to open the mandibula, but also elevating the hyoid bone. And now we're going to talk a little bit about how this action can be disturbed. So imagine you have, you're all sitting right now. I think, perhaps not, but I would assume that you're all sitting. If you have, for instance, now, if you flexing your trunk forwards, I'm trying to do this as we speak. You have a client with a passive seating tendency, and then we're going to divide the cervical spine into two zones. C1, C2, because that's a big influence, a big movement of the cervical spine in terms of rotation and extension and flexion. So about 40 to 50% of the flexion extension movement and the rotation is caused by C1, C2. And then we have C3, C7. That's the rest of the cervical spine. And that if you have a client with flexion, and then the bottom part of the cervical spine, C3, C7, is also in flexion. And then you have to have a hyperextension of your neck muscle of your upper cervical segments to look forwards. And in that position, try to follow me. I know it's a little bit difficult, but try to follow me. If you now collecting a little bit of saliva, and in that position, with your head in hyperextension, the cervical spine in hyperextension, so your chin would be elevated and forward. Try to swallow the saliva that you produce in the front of your mouth. And it's going to be really difficult to bring the tongue backwards. And that's, again, the suprahyoid muscles making it really difficult for the tongue to move upwards and backwards. And that's because the hyoid bone is unstable. And you see the same with a full extension pattern, and we call that hyperextension C1, C2. Hyperextension of the rest of the cervical segments, and then a hyperextension thoracic, a posture that we can expect for clients with, for instance, a symmetric tonic neck reflex or an extension of the trunk. And in that position, it's also really difficult to move saliva backwards, again, because the hyoid bone, where the attachment of the muscles of your tongue is happening, is unstable. The suprahyoids are being elongated and stretched. And then it's really difficult to migrate the bolus from the front to the mouth to the back of the mouth. So typically you would see that clients with a challenge like this, with this particular position, and Filipe is going to discuss the position with you, have a difficulty moving food from the oral vestibule to the palatoglossal regions, so towards the back of the oral cavity. And we also have a beautiful example here with a couple of client pictures. We see on the picture on the left, you can probably already tell what the problem is there. We have an asymmetric tonic neck reflex series kicking in here. And with an asymmetric tonic neck reflex, you have an asymmetric movement of those digastric muscles. And that makes it really difficult to receive the bolus and bring the food from the bolus backwards in the tongue. And on the picture in the middle, you see a C1, C2 hyperextension with a C3, C7 flexion and a T1, T12 flexion. So remember, that was the protrusion or the mandibula forwards and upwards, the hyperextension of C1, C2. That's nearly impossible to migrate food backwards. So typically you would see that people receive food and it stays there. It's not moving on to the next phase from the oral to the pharyngeal phase. And then the client is basically not feeding himself. He can't swallow it. And then a full flexion, we didn't discuss this, but if you have a full flexion, your head is flexed, your C-spine is completely flexed, upper and lower segments, and T1, T2 is also flexed. Then you're kind of leaning on the inferior part of your mandibula. That makes it really hard to open your mandibula. So your mandibular depressors responsible for opening your mouth are having a hard time. Again, that's the suprahyoid muscle group. Philippe, can you help us a little bit with seating interventions?
Yes, of course. Thank you. So now we need to take all this complicated information that we had from Mr. Bart.
What's complicated? I can't believe it.
and try to connect this, have this posture link with seating, right? So so that you guys know, we're working in a different presentation, and it's a global seating position presentation that we're working on, and we're not talking about that right now, but just to explain the image that we have. Like, can you just move forward on the slide part, please?
Absolutely.
So on this larger presentation, we kind of are looking at head positioning, of course, as a result of the relation between different segments underneath the head. Okay, so we divided or identified the segments that you see in the images. So I have the center of mass of the skull, which is right at the temporal area, like Bart mentioned. Then we have the C1, C2 vertebrae. Then we have C3, C7. Together they make the cervical spine. And then we have thoracic spine, lumbar spine, and the pelvis. We know that every one of these segments we can observe either a flexion or an extension. And in terms of the pelvis, we can see an anterior rotation or a posterior rotation. Those relationships between the pelvis, the lumbar spine, the thoracic spine will influence what's going on with the cervical spine. And the cervical spine, like Bart explained to us earlier, is divided in C1, C2, the axis and the atlas that are responsible for about 50% of extension and flexion, and also rotation, right? So if you fix your cervical and you just nod, this is the C1, C2 joint that is doing that. And then you have C3, C7 that does the rest of the movements, okay? So we all know that head positioning, cervical positioning, is affected by whatever is happening behind or underneath it. And this is what we're going to discuss in the next slide. In particular, when we talk about the protraction, which was the first example that Bart gave. Bart, can you move on, please, on the slide?
Absolutely. Sorry. Yeah.
So on the protraction, there's a lot of things that you can see right now. First of all, if you look at the image in the left, you see what Bart was talking about. So Bart was talking about, in the oral phase, the mandibular depressors, okay? So my problem right now is that the situation is that I'm dividing the swallowing process in 4 different phases. And what we're going to do is for each of the phases that Bart is going to explain to us, we're going to do a seating intervention. We're going to identify my seating problems and what I should do to correct those seating problems. Having in mind that if I'm trying to accommodate whatever is going on the cervical area, I need to first see what's behind or underneath that cervical area, okay? So if you look at the picture on the left corner, you want to see the open mouth. So this is what Bart was talking about. If I have that flexion of the C3, C7 and the hyperextension of C1, C2, I'm going to have those muscles in hyperextended. So I'm not going to be able to control my opening and closing of the mouth. And this is going to affect everything, this oral phase, mandibular depressors phase that Bart identified. So I have my pelvis in this particular case, with a posterior pelvic tilt. I have my lumbar and my thoracic spine flexed. I have my C3, C7 flexed as well. And I have an hyperextension of the C1, C2. Can you move on a little bit, Bart, please? Bart. So in terms of interventions and what I should do in terms of intervention.
This is
sorry, it seems like our signal is not that good. So in terms of interventions, starting from the bottom to the top, Obviously, we'll need some kind of cushion, anatomical cushion with a pri-IT support. I think this is basic for everybody. I have a client that is sliding off the chair. I have a posterior pelvic tilt, so this is the way to correct it. Obviously, the anterior supports are needed here as well. And I will also need to have some kind of PSIS push to either correct that posterior pelvic tilt or accommodate it and stop that rotation to keep on going backwards. So I'll do that PSIS support, and this is really important that everybody understands, not with a cushion, but with a backrest, okay, or the back support. The back support is the one that is going to give me that extra support at the PSIS level, okay? So then I will need, moving up, I will need some kind of upper thoracic retraction. I will achieve that with anterior supports, like a chest harness or H harness or something like that. And then moving on to the headrest, and you're going to see that there are a lot of headrests out there. You just need to be careful to, if you identify this type of need to a client, what type of headrest you need to use. Definitely, you need to have some kind of occipital support to support that retraction, and then maybe do a little bit of cervical traction, and then have an occipital higher on the skull to cause or provoke that flexion, because we want to control that there's the hyperextension on the C1, C2, right? So I can do that with a higher occipital pad and just pushing that back of my skull forwards. Can you move on to the next slide, please? The other situation that Bart was talking about is the full extension, right? So full extension when I have everything is extended. So I have my anterior pelvic tilt, I have my extension of the lumbar spine, thoracic spine, everything is extended. Even the C3, C7 cervical is extended, and the C1, C2 is hyperextended as well, okay? So if you look again to the corner left image, you're going to see that my mouth is open. So these are exactly the two situations that Bart was talking that will affect the mandibular depressors and prevent them from having the normal behavior and allow my client to close his mouth when he needs that, okay? So if I have a client that has a difficulty in closing his mouth and therefore has some kind of drooling, okay, if I have, even if it is in a passive seating and is drooling a lot, so I should look for this head positioning and obviously the entire seating positioning as well, okay? So in this particular case, what we need to have is, again, a very anatomical cushion with a pre-IT support. The use of anterior supports, again, it's essential here. Okay, I will need some kind of PSIS support, not a push, just a support at the PSIS level, obviously. And again, a good back support that allows me to control that recline, to try to control that hyperextension of the trunk as well. So I will need to cause or provoke some kind of flexion, upper thoracic flexion, to have some kind of control for that trunk extension, okay? Going up to the cervical, I will need two different things here. Again, I will have a C3, C7 extension, but I will need to have some kind of support, again, to give a little bit of cervical traction to control that upper extension or extension of the C3, C7. And again, with a high occipital pad, control the hyperextension of C1, C2. So every time I observe an extension of C1, C2 vertebrae or section segments, I will need to use a high occipital pad, okay? And every time I see also this, the best way is to have two different pads. I have an occipital pad and I have a suboccipital pad to allow me to have that alignment in a better way, okay? So every time I can see those two problems, my mouth is always open, it's difficult for me to close it, or I'm drooling, this is the type of interventions that I should look for, okay? Bart?
All right. Thank you, Philippe. Good examples. Trying to move on to the next slide here. Right, so we open the mouth, now we need to close it, right? And Philippe already said hyperextension doesn't work well closing your mouth. And the reasoning why is because you have a couple of muscles that are responsible for closing the mouth. And the first one is the masseter muscle. You can see the action here, the masseter, and then you have the temporalis, that's a big one. So you can see that a contraction there would lift the mandibular upwards and also retracts it slightly. So it helps with also grinding the teeth over the food and making it smaller. And then we also have the lateral pterygoid. So these are the, medial pterygoids. And you can see them here inside, they are smaller. They will be very important for closing the mouth. They are strong, but the explanation why your mouth pops open when you are relaxing or hyperextending, if you see clients, for instance, drooling a lot with the neck in hyperextension, you basically stretching the antagonists of the mandibular elevators. That's basically your suprahyoids, your mandibular depressors. If you're stretching them in a relaxed state of your mandibular elevators, your jaw drops and then you can have drooling. That also happens sometimes with us when we are sleeping in an appointment while we are seated with our neck backwards. I've seen this happening a couple of times on the plane, for instance, right? And then when you're mincing the food small, the big particles into smaller particles, we need to lubricate them. Saliva is produced by the salivary glands. The lubrication is done, but also the chemical digestion starts already from that stage, and it decreases also the risk for abrasion of gastrointestinal, pharyngeal, and esophageal lining. So it makes it easier to go to the pharyngeal phase after we finalized the oral phase. And you can also see that once the bolus is created, this smaller but flexible and compact bowl of food, now it needs to be transmitted from the front of the oral cavity, the oral vestibule, towards the back of the oral cavity. That's the palatoglossal arch. And at that stage, when the bolus touches the palatoglossal arch, an involuntary movement starts, and that's the next phase, that's the pharyngeal phase. But in order to move, in order to have tongue movement that's producing the food from the front to the mouth to the back of the mouth, you can almost compare the tongue now as a baseball glove, and there is a ball here. The ball would represent the bolus, and the tongue needs to build a trough around the bolus, and that's done by your intrinsic muscles of the tongue, cranial nerve 12. And then once you have made a ball, it needs to be moved upwards and backwards to the palatoglossal arch, so the involuntary phase, the pharyngeal phase, can start. And if your client has difficulties elevating the tongue and migrating the bolus backwards, and we see this very often with clients with a hyperextension of C1, C2, a flexion of C3, C7, and a flexion of T1, T12, and also with a hyperextension of C1, C2, C3, C7, extension and an extension of T1 to T12. That's basically your client with a hyperextension thrust or a symmetric tonic neck reflex. It's nearly impossible to move the bolus to your mouth. And typically or clinically, you would see that people in this phase with difficulties in this phase would have a mouthful of food, but they don't produce any swallowing reflex because the food stays, the bolus stays in the front of the oral cavity. And that can help you with these specific seating interventions that Philippe will give you again.
So just like the other mandibular depressors that Bart was talking about, the same seating interventions we have here in this particular case. Why? Just because we have, you can see two different scenarios, right? One is the open mouth, I'm drooling. The other one, and I have those protraction and full extension identified as a seating problem, that I should have some kind of seating intervention that we talked about. for this particular phase, it's called the bolus migration. I still have the same situations. I still have the same seating problems. I still have the protraction. I still have the pelvis, posterior pelvic tilt, a flexion, lumbar spine flex, flexion of the thoracic spine, flexion of the C3, C7, and then an hyperextension of C1, C2. So in terms of seating interventions, these I'm going to do exactly the same thing. So Bart, can you move on, please?
Yep.
Um,
Oops, I'm already one ahead. Yeah, here you go.
no,
Sorry.
just go. Yeah, that one. So all the seating interventions are as follows. I saw a comment. I'm just going to do a comment of someone that wrote something about the measurements. Obviously, that measurements of the cushion angles, seat to back angles, if we have tightness in the hamstrings or even the quads, all of that needs to be addressed. Okay, we just don't have time in an hour to talk about the complete seating intervention, but yes, measurements are something that we really need to be aware of. Okay, so in terms of seating intervention is exactly what we just discussed. We need to have an anatomical cushion, pre-IT support. I'm going to have a PSIS push with the back support. That's really important. Some kind of a retraction, upper thoracic retraction, and support the occipital retraction, and then have a higher occipital pad, just trying to control that hyperextension of the C1, C2. Okay, just move on to the next slide, please, Bart. And then we have the full extension. Bart.
Yep. There's a little bit of a lag here, so
Yeah.
sorry about that.
I'm sorry, that's fine. So in the full extension case, we also have the same type of interventions that we already discussed. So we're going to have to use the pre-IT anatomical cushion with using some anterior support belt at the ASIS level, have some kind of support at the PSIS with a back support again, achieve some kind of thoracic flexion, and then having an occipital pad separated from a suboccipital pad to allow to have some cervical traction with the suboccipital pad, so hold the skull and then control that hyperextension of the C1, C2 with a high occipital pad. Okay, so again, in those two scenarios, while I have the mandibular depressors with difficulty in closing my mouth and drooling, and the other scenario will be the bolus migration, so the difficulty in sending the bolus back by the use of the tongue. Okay, so all of these two different scenarios apply some kind of same seating interventions, if I may so. So I have a case of a protraction and the full extension. Okay, Bart, can you move on, please? Thank you.
All right. Now we discussed the oral phase. What can go wrong in the pharyngeal phase? Now the bolus reaches the palatoglossal arch. You can see this brown zone in the back of your oral cavity, and then it starts triggering a whole series of events. So it's an involuntary phase. It's basically you have afferent sensory fibers, cranial nerve 9, 10, and 11, into the oropharynx that are transmitting stimuli to the solitary tract of the brainstem, and that's basically triggering a contraction of afferent muscle fibers, and they travel to innervate muscles from the larynx, the pharynx, and the esophagus. So that's basically what happens. And in order to symbolize what will happen now and how we can work with seating interventions, I think it's important that you understand a couple of scenarios where your client can have difficulties. We try to symbolize this because now the muscles get really small and it's difficult to visualize them. But we try to make a cross section of somebody's head. You see this, the cerebrum, brainstem. You see the eyes here. You see the nose. You see the beginning of the oral vestibule and the mandibula. So hopefully that makes sense. I know it's a little bit vague, but you have a couple of scenarios. Remember, we want the food to go to the esophagus. We don't want the food to go anywhere else. But it's possible that the bolus moves towards the nasopharynx, and that's definitely not a good situation. So what happens then is the cranial nerve 9 and 10 will help contracting the uvula, and that's basically this part here. And if the uvula contracts, it's going to block the nasopharynx. So that's protection number one. And then you have a second protection and a third protection. And the third protection is tensing and lifting the soft palate. So that's another scenario. And there's two muscles which are responsible for this: the levator vili palatei, and then you have the tensor vili palatini. So that's this one, and that will tension the soft palate, and the other one is contracting and pulling it upwards. So it's protecting from the bolus going to the nasopharynx. So that is, so the contraction of the uvula, you can see this. And the second option is, and that's definitely a very bad option as well, you have the option that there is bolus, or the bolus is directing towards the larynx. And if it goes into the larynx, that could be life-threatening for your client. So, but there is a protection. There's a couple of protection mechanisms. So if this happens, the vocal cords will adduct, so it will close the glottis. So the glottis is a space between your vocal cords. And if that's basically closing, it's going to clear off the larynx, and it's going to protect food from entering into the larynx. And the muscles, the two small muscles, the lateral cricoarytenoids and the oblique arytenoids, help closing the epiglottis. And what you also see is people that have a little bit of bolus or a little bit of moisture into the larynx, they are scraping their voice. That's an indication that the vocal cords have adducted and that there was some of the bolus going into the larynx. But you will also see that the epiglottis, this valve here, is bent downwards. We call that a retro version of the epiglottis, and that helps also to close off the larynx from food entering. Pharyngeal phase serves actually also to protect the airways. We call that swallowing apnea, and that's a physiological response, closing off the larynx just to make sure there's no food going into the larynx. And that can take up to 0.5 up to 1.5 seconds. So you have apnea during this. That's usually when you are exhaling, just to make sure that you have the least amount of disruption from airflow. But that's important. And another factor that is really important is the migration of the tongue. If the tongue is migrating backwards, so this red thing here is the tongue. It helps you to basically envelop that bolus and also bring the bolus to the back of the palatoglossal arch. Well, but if that's disturbed, it will also disturb the migration of the tongue backwards, and that doesn't help with closing off the epiglottis. So clients that have already a problem with the oral phase will also more likely to have problems with bolus entering into the larynx. So that's definitely a difficult situation. So what we want is that the best scenario is that the food moves towards the esophagus, towards the pharynx. And when it's arriving in the pharynx, we have the palatoglossal arch, which is contracting, the palatopharyngeal arch also contracting. So it's slowly moving the bolus from this to there, always further backwards. And then you have the outer longitudinal layers that contract and they elevate the pharynx. So it's helping also to bring the pharynx closer to the bolus. And then the inner circular layers contract, and that's basically also causing peristaltis, moving the bolus backwards. And we see the suprahyoid muscles. And remember, we had those also being responsible for problems in the oral phase, where your client was not able to migrate food from the front of the oral cavity to the back of the oral cavity. But now the suprahyoid muscles, they will pull the hyoid bone upwards. And if that's happening, it's going to lift your larynx anterior also towards the bolus. So it's bringing everything aligned, so there cannot be any problems happening. And at the same time, when this is happening, it's also going to close the epiglottis, protecting the larynx. And then the upper esophageal sphincter will start contracting. And when the food or the bolus is reaching the upper esophageal sphincter, we're entering the next phase, which is the esophageal phase. There is definitely a link with posture because the main movements or bringing the pharynx closer to the bolus is basically caused by the action of the longitudinal layers. And they will elevate the pharynx and the larynx, closing the epiglottis, so also helping protecting the airways. And that is becoming very difficult because of the anatomy of this. If you're flexing your cervical spine, this muscle will become it's becoming shorter, and the contraction is not leading to an elevation of the pharynx and the larynx, and that is a problem. And in addition to this, we also discussed previously in the oral phase that the suprahyoid muscles are helping to stabilize the hyoid bone, and if that's also together with the C1, C2 flexion is being disturbed, remember some of the suprahyoids are in yellow here. If there is flexion, they are also less effective in stabilizing the hyoid bone. And then the epiglottis is not closing, and it can be a life-threatening situation for the client because food can enter the larynx. And what we also see is that if you have an asymmetric head position, you see that one side contracts, the other side doesn't contract. It doesn't help with centering the bolus towards the larynx. It can shift towards one side or the other side, and then it can also be a more threatening situation for food or bolus, or the bolus entering into the pharynx, into the larynx. So that's a problem. So C1, C2 flexion is therefore a problem. So in this position, trying to go into the pharyngeal phase, swallowing food from the oral to the pharyngeal phase, is seriously dangerous. C1, C2 flexion, you have also an asymmetry. The closing of the epiglottis is compromised. The suprahyoids are not stabilizing the hyoid bone, and the tongue migration and the food is having difficulty migrating the bolus backwards to start the esophageal pharyngeal phase. I'm sorry, pharyngeal phase. Yeah, Philippe, what can we do there? We need to do something.
Yeah. So at this pharyngeal phase that Bart described, we also identified two different postures that have a direct link, all of them connected with the flexion of C1, C2. Okay, so in this particular case is the full flexion case where everything is flexed. Can you just move on to the, exactly, thank you. So everything is flexed. I have a posterior pelvic tilt, flexion at the lumbar spine, thoracic spine, C3, C7, and C1, C2 flexion as well. So, you know, there's a lot of different pathology diagnoses and clients that we see with this type of posture. Obviously, you know, we need to have a pre-IT support, an anatomical cushion. The use of anterior supports is essential in this particular case. The BSIS push at the BSIS level done with the back support is essential as well. So I'm going to look for some kind of upper thoracic retraction, okay, and support the occiput retraction as well. So in this particular case, the headrest, the head support that I would be using would be something simpler, probably an occipital pad, or someone that will conform around the neck but doesn't need to do any cervical traction or something like that. Okay, can you move on to the next one, please? We saw that flexion of C1, C2 is definitely a case, a problem into this pharyngeal phase that Bart so well described. So the second case that we identify for this particular phase, and I want to make sure again that you guys understand that we're not talking about the swallowing process as a whole. We're trying to identify the different phases that Bart described, and then trying to have a seating intervention for all of them. Obviously that the head positioning will depend on the cervical flexion, extension, and so on, will depend on all the segments that we talked about. Obviously, we're going to we need to be careful with measurements, with seat to back angles, with seat angles, you know, the measurements, the width and the length, and if I have tightness of the muscles and so on, all of this will interfere with the position. We're trying to just, in a broader way, to try to show you guys what are the seat interventions that we're looking for every time we have we have problems in the pharyngeal phase. Okay, so again, in this particular case, anatomical cushion with the pre-IT support, essential. Anterior support close to the ESIS is also essential. I need some PSIS support done again with the backrest. And because I have some kind of back support problems with angles, I'll probably need to reduce the amount of recline of the back. So control that seat to back angle to try to cause some thoracic flexion and control that flexion on the C3, C7, and then the flexion of the C1, C2 as well. Okay, so this will allow us to, if I have a client with this pharyngeal phase problem that Bart just described, this probably would be the best seat interventions for us to look at. Can you move on, Bart, please? Thank you.
All right, and we're almost there. Now the food has entered or reached the upper esophageal sphincter. And now we can start with peristalsis. The food can move downwards to the lower esophageal sphincter into the stomach. You can imagine that if there is a lot of abdominal pressure, an increased abdominal pressure, perhaps from a full flexion pattern, it's possible that it's causing stress at the lower esophageal sphincter and reflux can occur. So if that's the case, the full flexion pattern can also help to decrease pressure at the abdominal region. And that is then because that is where the pressure is. And Filipe is going to help us with some flexion, full flexion.
Yeah, so in the case of this fourth and last phase, oral phase, the esophageal phase, again, being identified the cervical flexion as a problem. Again, we have the full flexion case. So the city interventions, we already discussed them. I'm not going to lose a lot of time, but just from the bottom to the top, pre-IT support, anatomical cushion, the use of anterior support is essential again. I don't get tired of saying the same thing. PSIS push, again, with the backrest. It's the backrest that needs to control that pelvis. It's not the cushion. Okay, so you need to be aware of that. We need to look for some thoracic retraction. And in terms of the head support that we'll be using, some occiput support in retraction, that will be a simple head support. Can you go back just one slide, please? Just one second. Just keep in mind that when we're talking about the seat interventions, we are not going to detail of all of them, because we know, again, that there is a lot of things and every client is a different client, right? So, this is a generic approach to a broader problem. So we're not trying to say that everybody is going to use the same type of intervention. I think, Bart, you agree with me. We're just trying to give you some guidelines to what we should look for every time we have one of these oral phases.
Yeah, and it's not just that. You can identify different phases and what goes wrong in every phase, and then you know specifically what seating intervention you can do.
Exactly. Yeah. Thank you, Bart. So in this particular case, and this is one of my favorite images of the video that we have from Leslie. Leslie is using a head support. It's called the I2Y. The I2Y is a head support that it's kind of a neck support actually, that allows Leslie to achieve that proper midline alignment and have every single muscle that we describe, every oral phase done properly, so that she can chew, she can bring the bolus back, she can swallow, she can breathe at the same time. You're not having all these problems that we identify. So the head is at the midline, very well aligned, and we achieve that not only with the head support that I just mentioned, the I2I, but obviously with every seating intervention underneath the neck that we don't see in the image, but the backrest, the seat, measurement, seat to back angles, all the anterior supports, the lateral trunk support, and so on. All of this obviously is a part of the seating intervention that we have in this particular case. Bart?
Absolutely. All right, I'm going to leave you with a literature review that was done to look at different assessment scales that you can use. Remember, you don't have to be a speech therapist to do them. Some of them are actually quite simple and very basic, and are used frequently by non-trained staff actually, or basic caregivers. So they are user-friendly and they have a value. This study, which is I think free to download, will give you an overview of different assessment scales and their validity with different client populations. And then I give you a couple more. The most famous ones are these here, mainly used for stroke, people suffering CVA. You basically look at different postures, swallowing in different postures, and looking at different circumstances where things go wrong. And you can look them up. And I also want to leave you with the GUS scale, because time is a little bit short here. And the GUS scale is probably an interesting one because it gives you, it's probably very frequently used in most countries. And now the link with what we've done is basically have this scale here in front of you. Swallowing is not possible. If swallowing is not possible, oral phase, migration perhaps of the tongue, moving the food backwards is a problem. And you basically see this if people have food sticking in their mouth. So that could be, or it could be even be an oral phase where people have difficulties producing saliva. If there is a cough, that basically means that the food is going to the larynx. That is dangerous. And think about the intervention that Filipe said. You have to want to close the epiglottis. And again, the suprahyoids are important there. And if drooling is a problem, especially during rest, that probably means that there is a hyperextension of the cervical spine. We discussed that as well, because it stretches the mandibular elevators. And if it is a voice change, that basically means that there is food in the glottal area, and there's scraping the voice because the cricoids muscles which duct the vocal cords have been working, and there is some kind of food spill into the larynx, and we also discussed those interventions. So the point is that these different types of problems on the scale, you can link them to the different phases of the swallowing process, and you can probably link them then, if you're comparing the posture, you see that it's very likely that the client has a similar posture as the ones that we discussed, then you know what to do, right? So if people tell you to do a seating intervention, and you don't really know what the problem is, it doesn't make sense, right? And that's perhaps the essence of today. You need to understand the different problems in the different phases for you to be able to make a smart and an educated decision. And then you can compare the postures with what happens with the biomechanics, and then you know exactly what to do, right? All right, I hope that makes sense. You had a couple of questions. I think Filipe addressed most of them during the presentation. There is also a question here, like a chin tuck, does that work? Yeah, it probably doesn't work in a pre-oral or in an oral phase. It probably makes sense to do in the pharyngeal phase, but then you have to do an assessment. Is it because of the cranial nerves being damaged, or is there a problem with closing the epiglottis? So you have to be more specific to give a good answer on this. I think the whole purpose of today was to be very specific, to give specific answers to that. Yeah. Filipe?
Good. I think we're done. Can you move on to the next slide, the references? Just
Yeah.
let you guys can see a special shout out to Leslie Fitzmans, a wonderful therapist, PT from New Jersey. She was the one doing the first study of the video of Leslie. Actually, she's the dystonic client that we saw. So a special shout out to her on this presentation as well.
Yeah, thank you all for attending.
Thank you.
And with that, I'll also give out the CEU code, which I'm also putting in the chat. It's Y14224.